Остановить трансляцию.
Две шага. И сюда, даже.
Да.
А сейчас мы уже начинаем.
Сейчас.
Спасибо большое. Good afternoon, students. We are going to start lecture. The topic is precancerous and malignant diseases of genital organs, female genital organs. I have no conflicts of interest regarding this topic. And we will start from the beginning, from the disorders of and diseases of vulva and vagina, which may be precancerous or even malignant. All precancerous conditions of the vulva are diseases which can develop in carcinomas called preblastomatosis. Chronic dystrophic processes without cellular dysplasia and cellular atypia characterized with proliferation and atrophic changes, but not an invasion. So when there is no invasion, but characterized with proliferation and atrophic changes, this is dystrophic processes and non-malignant. Non-inflammatory vulvar pathology can be found in women of all ages, but is especially significant in women of perimenopausal age, before menopause and right after menopause, because they're concerned regarding the possibility of real vulvar neoplasia. Non-neoplastic epithelial disorders of vulvar mucosa are lichen sclerosis, squamous hyperplasia, and other dermatoses. Also, we sometimes say we have mixed non-neoplastic disorders, which can be, although premalignant. Major symptoms of any vulvar disease are pruritus, which is itching, burning sensation, non-specific irritation, and appreciation of a mass on vulvar area. Vulvar region is particularly sensitive to irritants, we can remember it, than more than other region of the body because of wide innervation. Because vulvar lesions are often difficult to diagnose, the biopsy of vulva is central to good care of female patients. What is lichen sclerosis? It's very often confused with clinicians and pathologists because of inconsistent terminology and its frequent association with other types of vulvar pathology, including those of the acanthotic variety. As with other disorders, chronic vulvar pruritus occurs in most patients. Typically, the vulva is diffusely involved with very thin, whitish epithelial areas termed onion skin epithelium. The epithelium has been termed also as a cigarette paper skin, or described as parchment-like skin. Look at the picture, and you see here that in severe cases, lichen sclerosis is looks like this parchment-like epithelium. Normal anatomical landmarks on the skin are lost, including obliteration of the labial and periclitoral architecture, sometimes resulting in fusion of the normal labial and periclitoral folds, as well as severe stenosis of the vaginal introits. This is very often can be seen by gynecologists or family care physicians in late postmenopausal age. Lichen sclerosis is associated with increased risk of squamous cell cancer of the vulva, and the risk is estimated in the range of 4%. Unfortunately, the distinct etiology of lichen sclerosis is not known by scientists and practical doctors. Although familial association has been noted immune disorders, including thyroid gland disorders, and class 2 human leukocyte antigens. As I mentioned before, biopsy is the critical point of diagnosis of any valvular dystrophic disorder. So you can do excisional biopsy or punch biopsy like shown on the screen. Rarely immunology tests can be done for autoantibody screening, and microbiology swabs can be taken from the skin of various lichen sclerosis located, but it's routinely not recommended in many cases, in all cases. So punch biopsy, excisional biopsy is of paramount importance for diagnostic purposes. What can we see during the histological examination? A band of chronic inflammatory cells consisting mostly of lymphocytes in the epidermis with a zone of homogeneous pink staining collagenous-like material beneath the epidermis due to cell death. The retapegs, normally, which are projectile in appearance, are flattened, like shown on the lower picture. See, those retapegs are flattened. And on the upper picture, they're quite prominent. You see these retapegs. The obliteration boundaries between the collagen and bundles gives the dermis a hyalinized or glassy appearance. This dermal homogenization or sclerosis pattern is virtually pathognomic. Up to 35%, one-third of patients, there are associated areas of acanthosis, which are characterized by hyperkeratosis. You see, so thick is this membrane. Treatment of lichen sclerosis patient lies in a better personal hygiene and using only cotton underwear, not synthetic one. As for the treatment itself, the use of topical high steroid creams like 5% clobetasol preparation, 0,05 clobetasol preparation is an effort to ameliorate symptoms. So corticosteroids, very potent drugs which are applied superficially, they may help to relieve symptoms and the conditions. Patients in whom a large acanthotic component has been found should be treated initially with well-penetrating corticosteroid creams, such as 1% hydrocortisone aqueous cream. Don't forget about oral retinoids or vitamin A analogs, also oral antihistamines and topical antipruritic agents for itching relief, pruritus relief. Local applications of estrogen cream, especially for postmenopausal women, are recommended or strongly recommended. The brand name is Ovestin, but there are many other brand names from the pharmaceutical market. So estrogens inside the cream is important. Quite rare, but methotrexate, which is cytostatic, the preparation and other immunosuppressive agents may be administered. Also, some surgical approach like cryosurgery, photodynamic therapy, UV phototherapy, even laser ablation with simple valvectomy can be recommended, but in very rare cases. Another lichen problem is lichen simplex chronicus, which is much close to lichen sclerosis, but nonetheless it's slightly different because previously we called it neurodermatitis, valvular neurodermatitis, occurring in normal skin, which becomes extremely dry, thick, scaly, white, but sometimes pigmented and fissured in response to the permanent trauma and scratching. And lichenification is a similar change which is superimposed on another pathology, for example, like eczema or a contact dermatitis. These lesions are usually not symmetrical within the vulva and usually occurs in areas where they are accessible for scratching. On clinical presentation, the skin of the labia majora and labia minora and perineal body often shows diffusely reddened areas with occasional hyperplastic and hyperpigmented areas, spots, plaques of red and reddish brown color. Treatment of lichen simplex, empirical one, usually include antipruritic medications like diphenhydramine, brand name is Benadryl, but many other brand names maybe, that inhibit scratching. They combined with mild to moderate topical steroid cream applied to the vulva usually provides good relief. A steroid cream, like we mentioned before, hydrocortisone, 1 or 2% cream, or triamcinolone or betamethasone also can be used. If significant relief is not obtained within 3 months of the treatment, this empirical treatment, you need to proceed for vulvar via biopsy, as I mentioned before. The last one is lichen planus, a very rare inflammatory skin condition that can be generalized or isolated to the vulva and vagina. Patients may have areas of whitish, lacy bands, whitish, so-called Wickham stria of keratosis near the reddish, and in here as well, you see this region, and around the reddish ulcerated lesion, which is characteristic for the disease. Typically, complaints include chronic vulvar burning or itching, constant dyspareunia, painful intercourse, superficial dyspareunia, and profuse, abundant vaginal discharge. So don't forget about this lichen planus. Biopsy is warranted to confirm diagnosis in many patients, I would say. In lichen planus, biopsy usually shows no atypia, so it's not malignant condition, although we consider it as a pre-malignant. Examination of the vaginal discharge of these patients frequently reveals number of leukocytes, bacteria, and because of the secondary infection. Histologically, the epithelium is very thin, and there is loss of the retipex, ridges, with lymphocytic infiltration just beneath, associated with basal cell liquefaction necrosis. Treatment of this condition usually modification of their hygiene and normal treatment of topical steroid preparations, usually similar to those we use for lichen simplex, chronicus, like hydrocortisone 1-2%. Safe for steroids, tacrolimus preparation or methotrexate can be used, and patients should be also counseled that lichen planus is a chronic condition and goals of the treatment are realistically to control the symptoms and not to cure completely the disease. So the treatment of lichen planus usually just to relieve the symptoms, to cause better course this disorder, dystrophic disorder. This is just slide shows us differentials between those three lichens: lichen sclerosus, lichen planus, lichen simplex chronicus, and you see this lichen sclerosus cigarette paper, patch-like paper, and lichen planus white lacy network, Wickham stria with red color, reddish color, ulcerated lesions, and lichen simplex sclerosus, usually hyperplastic plaques of red and reddish brown color. If we speak about real neoplastic process, we usually call it VIN or VIN, like the vulvar dermatosis, the classification, the terminology widely used. So low-grade squamous intraepithelial lesion of the vulva means that pathology, abnormal cells with some atypia, they located in the epithelium, in just within epithelium. And in case of low-grade pathology, these atypical cells are not prominent, but in some extent we can see it on the pathology report. Demonstrates minimal or mild squamous atypia limited to the lower epidermis. Vulvar low-grade squamous intraepithelial lesion, either a non-neoplastic reactive atypia or an effect of HPV infection. Vulvar LSIL occurs more often in condyloma acuminata patients. Lesions that are condylomatosis in origin do not have the features of attenuated maturation, pleomorphism, and atypical mitotic figures that are found in other forms of VIN. The features of vulvar low-grade squamous intraepithelial lesions shown on this slide. Uncommon histological findings, and there is little evidence that vulvar process is a cancer precursor. Previously, it was classified as VIN1, but in 2004, International Society abolished the term VIN1 from the classification system. So now LSIL must be made by biopsy, by pathology report, and the treatment is the same for condyloma acuminata patients. High-grade squamous epithelium lesion, which we call HSIL, vulvar HSIL, they HPV related. They represent true neoplasia with a high predilection for progression to severe intraepithelial lesions and eventually carcinoma of the skin of the vulva, if of course left untreated. So the chance and the risk for progression for real cancer of the vulva is very high in patients with high-grade SIL. Almost 60% of women with vulvar SIL or vaginal intraepithelial neoplasia, which we call VAIN, also have cervical HSIL lesions. So all is very related in this part of the region body. Furthermore, 10% of women with cervical high-grade intraepithelial lesions have either vulvar HSIL and vaginal HSIL. So very common findings in vulvar, vagina, and even cervix. Patients without obvious raised or isolated lesions should be carefully inspected by a colposcope, and we'll touch this instrument later on. You need to apply 5% solution of acetic acid to the vulvar with the gauze for 2-5 minutes, and then you can inspect by a colposcope. These areas must be selectively biopsied in multiple sites because we need to know what's the diagnosis definitely, and of course to exclude invasive carcinoma. Treatment for neoplastic diseases, the idea of the treatment to quickly and completely remove all involved areas of the vulvar skin. These lesions can be removed after appropriate biopsy, which can confirm or rule out invasive cancer. Removal options include wide local excision or laser ablation, if your facility has this kind of treatment, like laser device. A vast variety of non-surgical treatments for patients with vulvar HSIL have been reported, including ultraviolet phototherapy, corticosteroids, which we mentioned before, fluorouracil 5-FU, and imidazoquinolones, imiquimod. You can see those preparations on the pictures. 5-FU is poorly tolerated, I would say, by many patients, although it has acceptable response rate, so good cure rate, but many patients have many side effects of 5-FU. Imidazoquinolones, like imiquimod, has been shown to be effective and better tolerated by patients, even applied locally on the skin. So careful evaluation to exclude invasive disease is very important, as VIN is seen adjusted to 30% of squamous cell carcinoma of the valve. So you must be very, very attentive to those patients. The next disease of the valvular region is Paget disease, which can be seen in other parts of the organism, like on the breast, characterized by extensive intraepithelial disease, which gross appearance is described by fiery, red-brown, mottled with small dots, whitish hyperkeratotic areas. This is characterized by Paget disease. The histology of this lesion is similar to the breast Paget disease, with large pair cells of apocrine origin below the surface epithelium. Nice picture of the Paget disease patient. Treatment of this disorder usually is a wide local excision or even simple valvectomy, depending on the amount of involvement. Of course, it is done in a special gynecological department, sometimes in oncology gynecology department. Recurrences are more common with the disorder that with valvular intraepithelial neoplasia, necessitating wider margins when local excision of valvectomy is performed. So we came to the valvular carcinoma, which is real cancer of the valve, which is shown in this picture. Luckily, only 5% of gynecological malignancy is a valvular carcinoma. Approximately 90% of these carcinomas are squamous cell carcinomas. Squamous cell carcinoma of valve generally remains localized for long periods of time and then spreads in a predictable fashion to the regional lymph nodes, including those of the inguinal and femoral chain. Lesions arising in the anterior one-third of the vulva may spread to the deep pelvic nodes by passing regional inguinal and femoral lymphatics. Lesions 2 centimeters to 0.5 centimeters deep have an increased risk for nodal metastasis. So the bigger the lesion, the more chances to metastase this tumor. And we have FIGOR, which stands for International Federation of Gynecologists and Obstetricians. They define different stage, usually from stage 1 to stage 4, and also related to the size of the tumor and the depth of the tumor and the spread of the tumor and metastasis. And as you see on the slide, it's available on the net. You don't need to pay attention right now. Treatment of valvular carcinoma or carcinoma of the vulva is usually a radical valvectomy with bilateral node dissection. Actually, this picture is not a radical valvectomy, it's just from one side valvectomy. It's not correct here, so usually we need to remove the vulva with adjacent lymph nodes. Avoidance, but now in the modern medicine where patients with valvular carcinoma become younger, unfortunately, not only after menopause, sometimes before menopause, and those patients may be sexually active and want to be attractive ladies. Conservative valvular operations with unifocal lesions can be done. So elimination of contralateral groin dissection in unilateral lesions 1 centimeter from the midline with negative ipsilateral nodes. Postoperative radiation therapy to decrease groin recurrence in patients with 2 or more progressed positive groin nodes. And also with radiation therapy, you can apply chemotherapy, 5-FU plus cisplatin or mitomycin, and it's gaining favor for the treatment of vulvar cancer that require radiation therapy. So now approach a little bit changing, and we try to understand the risk of the progression of the disease, the stage of the disease. Prognosis of the vulvar carcinoma is approximately 70% of patients will survive for 5 years, and it's very good. Unfortunately, 5-year survival rates for squamous cell carcinoma stage 3 usually less than 50%, and for stage 4 only 15% of patients will live for 5 years after the treatment. Vaginal disease also can be precancerous, but frankly speaking, not quite often as for the vulvar and cervix. Sorry. Okay, these vaginal neoplasia usually occur secondary to cervical vulvar cancers that have spread to the vagina from the primary site of the tumor. Vaginal intraepithelial neoplasia, VIN, can be classified into 3 types: vein 1, vein 2, vein 3, and it depends on the involvement of the basal epithelial layers. If it involves 1/3 or just the basal epithelial, it might vein 1. If it involves up to 2/3 of the vaginal epithelium, it is considered vein 2, and vein 3 involves more than 2/3 of the vaginal epithelium. Vein is most commonly located in the upper third of the vagina. Finding may be particularly related to associated with the cervical cancer. So, as I mentioned before, usually these diseases are secondary to cervical cancer. It's shown on this picture, which is drawn by artist, located sites of the vaginal cancer just beneath the cervix, the posterior fornix of the vagina. The majority of the remainder of the vaginal carcinoma consists of adenocarcinoma, vaginal melanoma, and sarcoma. Small cell cancer, lymphoma, carcinoid cancers together make only 1% of vaginal cancer. So please remember that majority of vaginal cancers are adenocarcinoma and melanoma and sarcoma. FIGO also classified in 4 stages this disease. Usually stage 1 and 2 is quite acute stage, and stage 3 or 4 it's a chronic stage. And as for any malignant diseases, stage 3 and 4 usually we can fight with this disease, with cancer, but of course, usually we fight for the normal life, not for the completely cure. If we speak about stage 1 and 2, we quite often can overcome this disorder, this malignant disease. So treatment, usually surgery, radiation, and neoadjuvant chemotherapy. Surgery, radiation, and chemotherapy. The patient's sexual functioning and exact location, anatomical location need to be considered. Radiation would not be appropriate for cancers in close proximity to radiation-sensitive tissues. Some anatomical locations would preclude achieving an appropriate margin of resection, that surgery would not be appropriate. The overall 5-year survival rate for squamous cell carcinoma of the vagina is approximately 40%. And for the clear cells adenocarcinoma, 78% with stage 1 and 2 patients, so they have quite good prognosis. Melanoma is treated with radical surgery. Radiation therapy is used as alternative or adjunct therapy for special clinical situations. Let's touch the uterine cervix. It's very common problem, which is you can go to the internet and Google it, and you see how many information about premalignant and even cancer disease of the cervix. It's very common site of cancer. Usually, the real cancer, birth cancer, is preceded by precursor lesions, cervical intraepithelial neoplasia, CIN, that may or not always progress to invasive cancer. If left untreated, it will progress usually. Cervical cancer and CIN are caused by human papillomavirus. Please remember it also, that human papillomavirus, HPV infection, is a causative factor for cervical cancer and, of course, CIN. Worldwide, it's the fourth most common cancer among women after the breast, colon, and lung cancer. So probably is the first cancer of their female organs. Briefly, I'll remind you anatomy of the cervix. It is covered by squamous epithelium, vaginal part of the cervix. And in the cervical canal, we have columnar epithelium, cylindrical epithelium, and their zone, when they attach to each other, we call it transformation zone. Risk factors for cervical cancer: high risk HPV specimen, more than one sexual partner, or a male sexual partner who had sex with more than one person, first intercourse at early age, usually younger than 18 years, male sexual partner who has had a sexual partner with a cervical cancer, which may obviously had HPV infection before, smoking, heavy smoking, HIV infection, patients who had organ transplant, especially kidney transplant, patients who suffered with many sexually transmitted diseases like chlamydia, gonorrhea as well, patients who have had previously taking diethyl withdrawal. This drug is not used widely now in our countries, but in the United States, some patients used this DES for treatment of infertility. But it's not common now. History of cervical cancer or high-grade squamous cell intraepithelial lesions before, infrequent or absent cervical cytology screening test. So patients who did not have pap test before, they may be in increased risk for cervical cancer. Again, for the definite diagnosis, we need to do biopsy, cytology test, and biopsy. And of course, biopsy is a more reliable method for diagnosis. It's shown on the slide. Sorry. To do pap test, we can apply special spatula, brushes, cervical brushes, and to put it on the slide. And for the biopsy, we utilize special punch forceps or conchotomes, we sometimes call it, and samples of the tissue are taken and sent to pathology. In many countries, Bethesda system is used for classification. This is American one. Classification divides epithelial lesions into two categories: squamous lesions and glandular lesions. Please remember that cervix is covered by two different types of epithelium: squamous epithelium and columnar epithelium. In both categories, lesions are maybe precancerous or cancerous. Cervical intraepithelial neoplasia terminology were graded to CIN 1, 2, and 3. And now CIN classification system replaced earlier classification schemes which utilized the term dysplasia, which were graded like mild, moderate, and severe. Now CIN terminology is still used with current Bethesda terminology, which are low grade and high grade of intraepithelial lesion. Usually low grade encompasses HPV infection, mild dysplasia, or CIN1, but high grade intraepithelial lesions encompasses CIN2 and CIN3. And in some classifications, cervical intraepithelial neoplasia 3 is designated for cancer inside of the cervix. Look at this picture and you see the corresponding terms of different systems, like CIN on the upper part, and Bethesda is here, and histology report is here. You see, but what happens? You see, this is basal membrane, and it should be intact in healthy women. If atypical cells conquers 1/3 of the epithelium, we call it low-grade squamous intraepithelium lesion, or CIN1. You see it here. If more than 2/3 are completely conquered by atypical cells, intraepithelial, you see different cells, abnormal cells, they conquered all thickness of epithelium. This is CIN3 or high-grade intraepithelial lesion. So this is according to Bethesda system. But when invasion starts, when the basal membrane are lost or intruded by the cells, we call it an invasive cervical cancer. I think it's clear. Colposcopy. I mentioned before about this device, about this method of investigation. When I talked about vulval cancer or precancerous disease, very useful instrument for the office, gynecology office. It can be also, and primarily it was invented for the early detection of the cervical cancer. Colposcopy with directed biopsy is the standard of care for the disease detection. And colposcopy utilized binocular stereo microscope with magnification 7 to 15, light source with green filter to aid identification of abnormal blood vessels that may be associated with intraepithelial neoplasia. With colposcopy, areas with changes consistent with dysplasia are identified, allowing directed biopsy. Colposcopic criteria such as white epithelium, abnormal vascularity, punctation on the cervical surface help to identify such problem areas of the problem, areas of the disease. This is a photograph of the cervix, which with some problems on the cervix. You see, with visualization of we must see the squama columnar junction, which is stands for SCJ. We need to see this junction and for evaluation of the adequate or not adequate colposcopy findings. If the SCJ is seen, it's considered satisfactory. If it's not completely visualized, this colposcopy is considered non-diagnostic one. And the colposcopic assessment in such situation usually need to be go further with cervical conization or in the cervical curettage, because you don't see, in cases if you don't see the squama columnar junction. Treatment of the mild CIN usually lies in cryotherapy, local superficial cryotherapy, or laser ablation, electrocautery, or cold coagulation. Usually, healing process is complete within 2 months. You need to follow up those patients within 2 or 3 months, and you see completely healing of process of this pathology of this disease. Unfortunately, for the CIN2 and 3, you need to use excisional methods to remove the affected tissue to provide specimen for examination. These methods usually are called knife conization. So you do cone biopsy of the cervix, which may have CIN2 or 3. Very popular method is LEAP, which is also called LEEDS, large loop excision of the transformational zone. It's shown on the slide below, on the picture below. You see here the wire loop goes through the impaired cervix, and the piece of the cervix with the pathology can be sent for investigation. Laser conization or electrosurgical needle conization may be considered as alternative methods, but the mainstream for the treatment now either cold knife conization or LEAP or LEEDS procedure, which is done usually by high frequency waves generators. Usually these procedures are performed under regional anesthesia or light general anesthesia. After treatment for non-invasive epithelial cell abnormalities, CIN2 or 3, either by ablation or excision, a period of follow-up co-testing with HPV or cytology within 1 or 2 years after the treatment is strongly recommended. So we need to follow up those patients because we don't want to lose a progression to cervical cancer, real cervical cancer. In this follow-up testing is normal. Repeat this test in 3 years after the treatment, and then patients may return to the normal screening recommendations, which can be different in different countries, of course. If any of the follow-up testing is abnormal, then recolposcopy those patients within the cervical curettage as well. So cervical carcinoma is very common disease, and we need to fight against it because cervical cancer is considered a cancer which can be detected by locally. Sorry, one minute break. Sorry. Well, excuse me. So cervical carcinoma is quite can be detected and prevented by our medical measures. So again, cervical cancer is caused by human papillomavirus in more than 90% of cases. Two major histological types of invasive cervical carcinomas are squamous cell carcinomas and adenocarcinomas. CSS comprise 80% of cases, while adenocarcinoma or adenosquamous carcinoma only 15% of cases. Signs and symptoms are variable and non-specific. Maybe you will hear complaints of watery vaginal discharge, maybe intermittent spotting, maybe, and it's quite often postcoital bleeding. So bleeding from the vagina after the sexual intercourse. Often the symptoms go unrecognized by the patients, so many patients don't see the symptoms. Because of the accessibility of the cervix, Accurate diagnosis often can be made by cytology screening, colposcopy testing, biopsy, or combination of ultrasound, computed tomography, and very diagnosis of their additional diagnostic measures for the cervical cancer. As well, it's necessary to do lymphangiography, laparoscopy sometimes, fine needle aspiration can be done. At this picture, you see the stages of their disease from their early stage, like stage 1B, the first stage, and you see the spreading of the cancer. It goes to perimetria, to both sides of the uterus. And if surface of the cervix is broken, bleeding from the vagina, postcoital bleeding usually starts. For the stage 1A microinvasive squamous carcinoma of the cervix, treatment usually conization of the cervix in patients who desire future reproduction, or simple extrafacial hysterectomy. So it's the very early stage with microscopic cancer cells on the cervix, and you can treat it completely, cure completely with conization, removal of the cervix, or if patients doesn't want future fertility, simple hysterectomy. Stage 1, 2, usually treated by radical hysterectomy with lymph node dissection, or radiation therapy also can be applied. So both are stage 1, but already in this situation, lymph node dissection is recommended, or radiation therapy. For stage 1B, radical hysterectomy with lymph node dissection, or radiation therapy with chemotherapy should be considered. Stage 2, to be external beam and brachytherapy radiation with concurrent chemotherapy is recommended. So usually surgical approach is recommended for patients with stage 1. And unfortunately, even patients with stage 2, they already need to be radiated and plus prescribed chemotherapy treatment. So we need to be very cautious for patients with premalignant diseases of the cervix, which may progress to the cervical cancer, and this is a very aggressive type of the cancer. So even stage 2, usually surgery doesn't help much. Current guidelines for vaccine for HPV, because I talked to you and said, I told you that HPV is responsible for CINs and for cervical cancer as well. So HPV usually given in 2 or 3 separate doses. Usually, it's in many countries it is provided by the government support or medical care system support. The first dose usually recommended at the age before age 15. In some states of the United States, it's recommended to vaccinate girls at the age 11, 12 years, or sometimes even at the age 9 years. So we need to give this vaccine against human papillomavirus to create the barrier against the future changes of the cervical cells. Two common vaccines are Gardasil brand names. It's quadrivalent human papillomavirus vaccine against type 6, 11, 6, and 18 viruses, high-risk viruses. And Cervarix is another one against only 16 and 18 HPV specimen. But both of them are very effective for the vaccination, for the control of this disease. So the cancer of the uterus and precancerous disorders of the uterus. Approximately 2–3% of women develop uterine cancer during their lifetime. 97% of all uterine cancers arise from the glands of the endometrium, endometrial carcinomas. And the remaining 3% are uterine cancers. They arise from mesenchymal uterine components, which we call sarcomas or leiomyosarcomas. But anyway, cancer of the endometrium usually starts from endometrial hyperplasia, which is not malignant disease, but maybe pre-malignant in some patients. In 2015, World Health Organization simplified the classification for understanding of both doctors and patients, of course. So now only two types we can distinguish: hyperplasia without atypia and hyperplasia with atypia, so atypical hyperplasia. Simple hyperplasia is the least significant form of hyperplasia and is not commonly associated with progression to endometrial carcinoma. In this type of hyperplasia, glandular elements, stromal cells proliferate extensively. Histologically, glands vary markedly in size, from small to cystically enlarged, and this is pathognomic for hyperplasia, large glands. Complex hyperplasia usually represents abnormal proliferation of primarily glandular elements without concomitant proliferation of stromal elements. This increased gland-to-gland ratio gives the endometrium a crowded picture, frequently with glands appearing almost back-to-back. As the severity of hyperplasia increases, the glands become more crowded and more structurally bizarre. It is thought that complex hyperplasia represents a true intraepithelial neoplastic process, and it's occasionally found coexisting with areas of endometrial adenocarcinoma. Atypical hyperplasia with some atypia of the cells, characterized by a significant number of glandular elements that inhibit cytological atypia and disordered maturation, loss of cell polarity, nuclear enlargement with increased nucleus to cytoplasm ratio, dense chromatin, prominent nucleoli, and its real precursor to endometrial carcinoma. You see on this photograph, micro photograph of atypical hyperplastic process. The endometrium is place where endometrial polyps may rise, and those polyps, less than 5% may have malignant changes, but pre-malignant changes are quite common in the polyps of the endometrium. So it's shown on the photograph here, a hysteroscopic photograph, and this slide of this polyp. Polyps in postmenopausal women or women taking tamoxifen, the drug which is used by oncologists for the treatment of breast cancer, are more likely to be associated with endometrial carcinoma than those found in reproductive age women. The primary process central to the development of endometrial hyperplasia and most endometrial cancer is overgrowth of endometrium in response to unopposed estrogen stimulation. Sources of estrogen may be endogenous, like from the ovary, or peripheral conversion from the androgens, or maybe exogenous, which we doctors give our patients for the treatment of postmenopausal symptoms, for the treatment of osteoporosis, for example. The risk factor for hyperplasia and endometrial cancer are identical. In one study, more than 42% of women with endometrial atypia had invasive endometrial cancer demonstrated after hysterectomy. Clinical signs of endometrial hyperplasia, atypical endometrial hyperplasia, and even for endometrial cancer is abnormal uterine bleeding. Risk factors for this premalignant disease: family history of the breast cancer, family history of colon cancer, and also the gynecological cancer like ovarian cancer. Don't forget that obese patients are in a risk group. Patients who previously in the young age they had endometrial hyperplasia. Patients with chronic anovulation, like patients with polycystic ovarian syndrome, and patients who took tamoxifen for the breast cancer treatment, or patients who even didn't have any cancer but was on hormone replacement, menopausal hormone replacement therapy with estrogens. First, we need to evaluate endometrium. It's maybe done by dilation and curettage procedure, or hysteroscopy, but on a practical point, we usually start from ultrasound, and on ultrasound investigation we can see the thickness and the echostructure of the endometrium. And usually, if the thickness of endometrium more than 15 millimeters in women of reproductive age, it may be suspicious for premalignant disease of the endometrium, or even malignant disease of the endometrium. And for postmenopausal women, the thickness of endometrium more than 4 millimeters usually indicative for the proliferation of the endometrium, maybe due to cancer of the endometrium. The primary goals of treating endometrial hyperplasia to reduce the risk of malignant transformation and to control the presenting symptoms. Synthetic progesterone or other synthetic progestins play the central role for the treatment of endometrial hyperplasia. In many Western countries, in the European countries, in the United States, and maybe in your countries, you find this drug. The name is MPA, medroxyprogesterone acetate. Usually it is prescribed in the pills for 10 to 14 days a month, up to the half of the year. In our country, we also prescribe progesterone, micronized progesterone therapy, 100, 200 milligrams a day, cyclically, 12-14 days per month. Usually it starts from day 16 of this menstrual cycle if this reproductive woman, or also we can prescribe and introduce special levonorgestrel intrauterine device into the uterus, into a uterine cavity. That brand name is Mirena, and usually only 20 micrograms of this levonorgestrel goes inside the endometrial cavity daily, and this Mirena may stand for several years, up to 5 years, and it demonstrated good response for the treatment of endometrial hyperplasia. In some patients, hysterectomy, extirpation of the uterus may be recommended if patient, for example, doesn't want to fulfill her to give more birth, to deliver more children. So in these patients, hysterectomy can be one of the options. But if we speak about endometrial cancer, endometrial cancer, usually this disease for postmenopausal women, but unfortunately, and patients with before menopause may suffer from this disease. Starting from the age 40, the chance for risk for this endometrial cancer is start to increase. Usually, 5 to 10% of postmenopausal women who have bleeding, they have endometrial cancer. Not all 100% with postmenopausal bleeding have endometrial cancer, up to 10%. Majority of cases are diagnosed in the stage 1 because many patients they understand this symptom. To have postmenopausal bleeding is many patients know that it may be indicated for endometrial cancer. Majority of the endometrial cancers are adenocarcinomas. In cases where the squamous elements is benign and make up less than 10% of histologic picture, this is adenoacanthoma. Uncommonly, the squamous element may appear malignant on histological assessment, and it is referred as adenosquamous carcinoma. Other descriptions like clear cell carcinoma, papillary cirrhosis, adenocarcinoma may be applied depending on histological structure, but mainly endometrial cancers are adenocarcinomas. Two kinds of endometrial carcinomas have been identified. Type 1, we call it estrogen dependent, accounts approximately 90% of cases. These cancers tend to have low-grade nuclear atypia, endometrial cell types, and usually these patients have better prognosis. The second type of the endometrial cancer is a type 2 or estrogen non-dependent. These patients usually have less differentiated carcinomas with poor prognosis. Unusual histological subtypes, including papillary serous adenocarcinoma and clear cell adenocarcinomas of the endometrium, tend to be more aggressive than more common adenocarcinoma. Endometrial carcinoma usually spreads throughout the endometrial cavity first, and then begins to invade then myometrium, adjust myometrium to endometrium, and the cervical canal, and of course may spread by the lymphatic system. Staging, again, usually we need to keep in mind that FIGO recommends to stage for 3 grades. G1, usually well-differentiated adenomatous carcinoma, less than 5% of tumor shows a solid growth pattern. Grade 2 is moderately differentiated adenomatous carcinoma, usually 50% of tumors show solid pattern, and grade 3 is poorly differentiated or completely undifferentiated adenocarcinoma. Greater than 50% of the tumor shows solid pattern. So grade 3 patients they had worse prognosis comparing to grade 1 well-differentiated adenocarcinomas. Very important to keep in mind the depth of the myometrial invasion. It's another one important prognostic factor. So grade is very important, and the depth of the invasion of the myometrium. On this slide, you can see the schematically stages of the endometrial cancer. The first stage, cancer is confined to the uterus only. Stage 2, it is here. Stage 2, cancer starts to spread to the cervix. Stage 3, cancer starts to spread to the vagina or to the ovary or to the lymphatic system. And stage 4 usually accounts for distant metastasis and invasion to the adjacent organs, even beyond the pelvic region. Treatment of endometrial cancer, usually hysterectomy for for early stage of the disease. Usually for the early stage of the disease, hysterectomy works well. The addition to the complete surgical staging, which includes bilateral salping oophorectomy, so we remove the adnexa, lymph node dissection, peritoneal washing, so we collect fluid with cells from the abdominal cavity, from the pelvic, small pelvis, is not only a therapeutic one, but also associated with better survival rate. Also includes pelvic washing, bilateral pelvic and periaortic lymphadenectomy, and complete resection of the disease, which may be to adjacent organs. Post-operative radiation therapy should be tailored to non-metastatic disease or used in case of recurrence. In patients with surgical stage 1, radiation therapy may reduce the risk of recurrence of the disease, but does not improve the survival, unfortunately. Women with positive lymph nodes, for example, in stage 3C, radiation therapy is critical in improving survival. So we need to do radiation therapy in stage 3 disease. Recurrent estrogen-dependent type 1 adenocarcinomas may be responsive to high-dose progestin therapy, We remember that progestins are antagonists for the estrogens. And for patients with estrogen-dependent adenocarcinomas, high-dose progestin therapy can be very effective, like Depo-Provera, 500 milligrams, may be prescribed for these patients usually on weekly basis. Leiomyosarcoma is the cancer of the myometrium. Uterine malignancy is more typical in postmenopausal women who represent with rapidly enlarging uterine masses. Postmenopausal bleeding, unusual vaginal discharge, pelvic pain. An enlarged uterine mass in postmenopausal patients should be evaluated with considerably more concern for malignancy than one found in the younger. Symptoms of uterine sarcomas: progressive uterine enlargement occurring in the postmenopausal years, postmenopausal bleeding again, unusual pelvic pain coupled with the uterine enlargement, and increase of unusual vaginal discharge. Treatment for uterine sarcomas, leiomyosarcomas, usually indicated in patients with documented and especially progressive uterine enlargement. The staging for uterine sarcoma is surgical and identical for the endometrial adenocarcinoma. Radiation and chemotherapy provide little survival advantage as adjuvant therapy for the hysterectomy. Adjuvant therapy, usually hormonal antagonists and analogs, aromatase inhibitors, progestins, gonadotropin-releasing hormones agonists. Ovarian and adnexal tumors. The area between the lateral pelvic wall and the corner of the uterus is called the adnexal space. The structures in the space are called adnexa, and obviously these are ovaries, fallopian tubes, ligaments, mesoesophagus, and remnant of the embryonic Muller ducts. Significant portion of all ovarian masses in postmenopausal women are malignant, whereas in reproductive age, women less than 10% of ovarian tumors are malignant. Pelvic ultrasound is a primary component of radiation. Simple unilocular cysts less than 10 centimeters in diameter confirmed by ultrasound are almost universally benign. Biomarkers may be helpful. For example, CA125 is a serum marker that is sometimes used for distinguishing benign or malignant pathology. Any CA elevation in postmenopausal women with a pelvic mass is highly suspicious for cancer, but not 100% diagnostic. Ovarian neoplasm characterized by cell type of the origin. So it's polymorph pathology. Epithelial cell tumors may be serous, mucinous, and endometrioid neoplasms. Germ cell tumors, stromal cell tumors, and other rare types of neoplasm. Quite common findings is a serous cystadenoma, which are precancerous but not real cancer. So the component inside, serous fluid. Treatment usually surgical because of the relatively high rate of malignancy. In younger patients with small tumors of simple ovarian cystectomy, removal of the cyst may be attempted to minimize damage of the ovarian tissue. Oophorectomy or adnexectomy, ovary with the tube, with preservation of the contralateral ovary, is indicated for a patient who desires future fertility. In patient after the reproduction, bilateral oophorectomy, sometimes with hysterectomy, is recommended. Another common type is mucinous cystadenoma, which may be quite large, epithelial tumor of the ovary. Malignancy is quite high, 50%. Another one is a benign cystic teratoma. Dermoids, they may contain different tissue like ectoderm, mesoderm, endoderm, skin, hair, fat, for example, fluid. Treatment of dermoid tumors depends on the size patient symptoms, surgical risk, and suspicion of the malignancy. Malignant neoplasm of the ovary is the fifth most common cause of the death in the women in the United States, for example. The mortality rate of this disease is the highest of all gynecological malignancy, primarily because of the difficulty in the detection of the disease. Ovarian cancer presents most commonly in the fifth and the sixth decades of life. Although now, unfortunately, we see many patients in the even 30 years old, patients with ovarian cancer. The risk of a woman developing ovarian cancer during her lifetime is approximately 1 to 70. Risk factors are age, the older the woman, the high risk for tumor to be neoplastic, nulliparity, so we need to emphasize that patients who don't give birth are in a high risk group. Obviously, patients with infertility, patients with endometriosis, which is related in many cases with infertility, and patients who had or who have mutations in the genes like BRCA1, BRCA2. The most common symptoms for ovarian or adnexal tumors are abdominal bloating, abdominal pain, low abdominal pain or discomfort, decreased energy and lethargy, early satiety with urinary urgency. Usually these symptoms occur more frequently and are more severe than in patients without cancer. Approximately 10% of benign epithelial cell tumors may contain histological evidence of intraepithelial neoplastic cells, and we call those tumors as borderline malignancies, tumors of low malignant potential. So approximately 90% of all malignancies are of epithelial cell types derived from mesothelial cells. Malignant epithelial tumors, serous tumors, serous adenocarcinomas are the most common malignant epithelial cell tumor. Another type is mucinous cystadenocarcinoma. Most of the endometrioid tumors are malignant. Don't confuse with endometriotic cysts. It's different. It maybe resembles to this one, but it's different. Endometrioid tumor of the ovary. Germ cell tumors like dysgerminomas or immature teratomas. Don't confuse with benign teratomas. Mature teratomas are benign, and immature teratomas are malignant. And also, we have many metastatic tumors, cancers of the ovaries, like, for example, Grukenberg tumor describes an ovarian cancer which is metastatic from other sides of the gastrointestinal tract or the breasts. In approximately 10% of the patients with cancer metastatic to the ovary, an extra ovarian primary site cannot be demonstrated. Carcinoma of the fallopian tube is very rare. Incidence is very low, only 1% of gynecological cancers. Signs are postmenopausal bleeding, followed by abnormal watery discharge, pain, pelvic mass. But as you see, these symptoms are very resemble what we discussed before. So very difficult to distinguish between adenocarcinoma of the fallopian tubes and, for example, cystic adenocarcinoma of the ovary. So staging is very important, surgical staging. And sometimes carcinoma of the fallopian tube can be found only during the surgery for adnexal tumors. Management of ovarian and fallopian tube cancers are very much close the same. Primarily, surgical therapy is indicated for most of the ovarian malignancies, so-called tumor debulking. Also, we need to do peritoneal cytology, palpation of the pelvis, paracolic sinuses, omentum, upper abdomen, including liver, spleen, diaphragm. Of course, we do, for this reason, omentectomy or resection of the omentum, sampling of the pelvic and para-aortic lymph nodes, very important. And for the treatment after the surgery, adjunctive treatment, chemotherapy is usually necessary. first-line chemotherapy is usually paclitaxel, the brand name is Taxol, or combined with drugs with platinum, carboplatin, cisplatin. And usually this is done by gynecologists and oncologists. So thank you very much for your attention for today, and I hope all the information I provided you was helpful, and you'll discuss in depth these diseases on the practical seminars with the teachers. Have a nice day.